Hello class, this is Dr. O'Shaughnessy, and I'm going to prepare and develop this week 2 lecture for you. First of all, I'd like to talk to you a little bit about the information that was assigned to you to read in Chapter 10 of your DA book, okay? And the title of that chapter is Reconstituting Parenteral Medications from a Powder. So let's just go over some of the important information from that chapter, if you haven't already read it. And some of the meds that we get up from pharmacy, in order to extend those shelf lives of those unstable liquid medications, manufacturers package, store, and ship these drugs in what we call a lyophilized form. And what we mean by lyophilized is it just means that the drug is what we call freeze-dried, okay? And these medications you may see labeled as either powder for injection, powder for constitution, powder for reconstitution, or either dry powder injection. And remember, these meds must be reconstituted before injection into a vein or into a tissue. And the fluid that we used to reconstitute these medications is what we call the diluent. And some of the solutions that are common dilutants that you would use to reconstitute these meds are sometimes D5 in water, or 0.9% normal saline, or you might see bacteriostatic water or sterile water for injection. And if you're not quite sure, what solution that you would use for a diluent, you could always look into the insert in the packaging, and it will provide you with that information. Often the diluent is supplied with the medication by the manufacturer, especially if it is an uncommon diluent. But never use a diluent that is not directed by the manufacturer, because sometimes it can make the drug unstable and it would not be safe to administer to your patient. Now, when we're talking about reconstituting powdered medication, your book recommends some very important steps to follow when we are reconstituting powdered medications. And your book provides 10 steps, and I'm not asking you to memorize them. I would like you to read these over and understand the reasons why, because then it will make more sense when we talk about some of the common errors that occur when people are reconstituting these medications. Obviously, if they're in the vial, if these medications or dilutants are in vials, you definitely remove the caps from the dilutants and from the medication vials and clean those vials as instructed by hospital policy, okay? And then you determine the amount of diluent to be added. And then, of course, as we learned from week 1, we want to choose the appropriate syringe size. And what you're going to do is draw air into that syringe as the same amount of the diluent that you're going to use. And of course, the next step makes sense. We would insert the needle and inject in the air, and we do not remove the needle from the vial. Then you're going to turn the vial upside down and then withdraw that required amount of diluent. And then, of course, you're going to withdraw the needle from the vial and insert that needle into the vial of powdered medication. So it goes into one vial where we draw from the diluent, and then we're going to take that syringe and put it into the vial that has the powdered medication and inject that diluent into that particular vial, okay? Now, the important thing to remember when we are injecting that diluent into the vial, that we inject it slowly, because you want to be very careful about creating a lot of bubbling and a lot of air into that vial. So that's why we make sure that we inject that diluent very slowly into the vial that has the powdered medication. And then we mix that medication as instructed by the drug label, and then we withdraw the required amount of medication into the appropriate syringe. So those are pretty much common sense when we're talking about going from a powdered form of medication to the reconstitution phase of injecting that diluent into that vial and then withdrawing that medication, and of course using the correct diluent as well. That's a very important part of it as well. Now, there are possible errors that can happen when we are reconstituting, and think about it. Since you are moving a needle from vial to vial, it's very possible that if you're in a hurry, needle stick injuries may occur when entering the vial. And when that occurs, you definitely would want to get a new syringe. And possibly your vials may be contaminated as well. So any type of needle stick injuries, you would definitely report to the nurse manager, and they would probably send you down to Human Resources and report the injury. Sometimes the medications may be contaminated as well. That's why it's necessary that when you remove the caps from those vials, that you wipe those clean according to hospital policy. Of course, if you select the wrong diluent, I just said that. Many times these manufacturers are very strict about what the diluent should be. Many times the diluent comes with the medication. So there's no question as to what is the choice of diluent to be used for that reconstitution. And of course, inaccurate doses may be administered if the wrong concentration of medication is mixed, and that would definitely be another serious error as well. So those are some of the possible common errors that can occur when reconstituting powdered to a liquid form of medication. Now, your book also talks about principles of safe reconstitution, and this is on page 169 in your DA book. And the one important thing to remember is when you add the diluent to that powdered medication, you want to dissolve all the powder and be sure the solution is clear before you pull that up or withdraw that medication. And to do that, that's why we encourage you and tell you to inject that diluent into that vial very slowly. And what I like to do is just take that vial and rub it very slowly between my hands and kind of roll it to hopefully dissolve all that powder. And then as you hold it up, you can tell that the solution is absolutely clear without any particles. And sometimes they can be very small, and they may not be caught with the human eye. So to avoid those small particles from getting into a patient's tissues, I would use a filter needle to withdraw that medication, and then you would change that filter needle if you were going to give it as an IM or a sub-Q. And then if you're giving it IV route, you would add an inline filter to the IV tubing. And then you're sure that those small particles will not be given to the patient via the vein route or from some other type of route. So that's what is strongly recommended when you're withdrawing those medications. But it takes a little bit to be patient and be sure that all the medication is properly mixed so that it's dissolved adequately and there's no clumps of medication. Okay? And that's where you avoid that vigorous shaking. Don't take the vial and shake it real hard, because what happens when you do that is when you shake it, it may cause the medication to foam, and foaming can activate some proteins in the medication and may delay administration while that foam kind of tends to dissipate. So follow the manufacturer's directions for mixing on the label, or look at the package insert, as we talked about last week. after you reconstitute the medication, it's important to write this particular information on the label. First of all, your initials, the date, the time of reconstitution, when that particular medication will be expiring, especially if it's going to be used as a multiple dose more than one time, and then the amount of diluent added and what the final concentration is. You know, if it's at 200 milligrams per each ml or whatever, but that's important to put on the label as well. Another important safety rule to remember is do not reconstitute too early, okay? Some medications may become ineffective a short time after you reconstitute them. So I know sometimes nurses want to keep ahead of what they have to do, especially if they're administering a lot of medications, but it will make the medication inactive and will not provide the outcome that you intend that medication to do. And then, of course, store medications, reconstituted meds according to the manufacturer's directions. And then, of course, disregard unused medications according to the facility policy. So we're trying to avoid people from pouring medications down the sink that get into our water system. There is specific facility policies and how we dispense or discard medications that are unused. So be sure to follow those. You know, we want to be green and be safe to the environment as well. That pretty much is the important information from Chapter 10. Now you can see from your booklet that there are some questions that you may want to go over. And then, of course, it talks about reconstituting single and multiple dose medications as well, because sometimes we may be able to use that reconstituted med another time, and other times there may be leftover medication in that vial that it's only for one-time use, and so then we would have to discard it appropriately. There are some great practice questions on reading labels and knowing how to reconstitute certain medications, particularly when you have the physician's order as to the dosage, how much of a diluent you would add to that particular medication. There is also a very nice chapter post-test that might be very helpful, since our first test is next week. And I'll talk about that in just a few minutes after I get done discussing the medications for this week. All right, and again, you know, keep practicing your DA problems, and be sure that you can do DA problems in solving for milliliters or milliliters per hour. And I will be most happy to take that PowerPoint and upload that in your Canvas course. Now what I'm going to do is talk about the meds that you should understand for the disease processes that you're going to learn in Nursing 122 lecture. The focus for this week is meds that you would see prescribed for patients who are diagnosed with asthma, COPD, and then for patients who are diagnosed with congestive heart failure, and for patients that are diagnosed with coronary artery disease. Now, I'm not sure if you've begun that lecture, but it's very important to understand the pathology and, of course, what is actually occurring with the patients, and then it makes better sense of why these particular meds are very, very helpful and extremely helpful, and may even save a patient's life and provide them a quality of life when they take them in the correct way. And this is where it's very important that as we talk about patient-centered care, that we really help our patients understand their medications and why they're taking them, and to take them correctly and to be aware of the outcome when they do take these medications. So let me go over these with you, and as you can see, we're going to begin with the respiratory medications with patients who have some type of respiratory problem such as asthma or COPD. I'm not going to get into the pathology of these disease processes. Your lecture instructor will give you that information, but I will state in a general term exactly where the problem is and into what structure of the respiratory system these diseases are occurring in. Now, when we talk about asthma, most of the problem is in the bronchioles, okay? And what happens when these patients have an exacerbation of their asthma, or they have a flare-up of their asthma where they go into some respiratory distress and have bronchospasms and bronchoconstriction, is along with that occurring, they have what we call a hyperresponsiveness and an inflammatory process as well. And sometimes this occurs after a person has had some type of upper respiratory infection. They might experience some kind of asthmatic response, okay? So the first medications that I'm going to talk about is albuterol, all right? And we look at that therapeutically as a bronchodilator, and pharmacologically it's a beta-2 adrenergic. And as you can see, I have the picture up that kind of talks to you about the different types of bronchodilators. And these little cartoons are uploaded in week 2 under modules in your Canvas course. Now, albuterol is a very, very important drug because this is the drug or a rescue drug that your asthmatic should carry with them at all times. Say, for instance, they go into some kind of asthma attack. They should have their inhalers with them. And albuterol can be given as an inhaler, giving themselves a couple puffs, and to be able to perform that action in the correct way. And when these patients are first diagnosed as asthmatics, it's very important that we begin that teaching on how to use their inhalers correctly and to have them wherever they go. And if women carry various purses, it's good to have 2 or 3 inhalers so that they have that inhaler in each of their purses, or maybe in their cars or in their bags if they're going to school, but to be sure that it's available and they have access to it at all times, okay? And why is this drug so important? Well, what it does is it relieves and prevents bronchospasms. It treats asthma and that acute shortness of breath, because what's happening is those bronchioles are becoming quite inflamed, and there's a lot of edema, and that's why these people also develop a lot of secretions. And of course what happens is those bronchioles begin to constrict and kind of get very small, so that now the lumen is very small for that air to pass through. And just think about it, what has to occur? That air has to go through the bronchioles so it will reach the alveoli and cross that semi-permeable membrane where the diffusion of gases takes place. And when that lumen and those bronchioles begin to constrict and get smaller, that's where that person may start to develop severe shortness of breath and really start to gasp for air. Respiratory rate starts to increase, heart rate starts to increase, and that's why it's so important to have this inhaler nearby so they can take a couple puffs. And what that albuterol will do is open up and dilate those bronchioles to allow more air to facilitate through the bronchioles to reach that alveoli where oxygenation and diffusion of gases takes place. It also helps to facilitate mucus drainage, and it inhibits the release of those inflammatory chemicals from mast cells. And it may prevent exercise-induced bronchospasms. A lot of time your asthmatics if they're very insensitive to the demands that are needed when someone begins to exercise strenuously, they may take a few puffs, a couple puffs before they begin their exercise regimen. So that's to prevent that bronchospasm from occurring. It selectively binds to those beta-2 adrenergic receptors in the bronchial smooth muscles to then cause bronchial dilatation. All right. Now, some of the adverse reactions that we see with albuterol is it can cause palpitations, headaches, throat irritation, and really give that person a sense of nervousness and restlessness. And it can also cause tachycardia. I've had albuterol one time. I was diagnosed a few years ago with a severe case of bronchitis, and I was just very miserable and very sick and had a high fever, and so I had gone to the urgent care, and they did give me a albuterol treatment. And I'll tell you what, it really opened up my airways and made me feel so much better. And you'll notice too, when a person begins to have bronchial constriction, that's where they develop those adventitious breath sounds such as wheezes, because that lumen, those bronchioles are getting smaller, and that's the air passing through that small lumen, and that's why you hear those wheezes. And so I remember, having that albuterol treatment, and it does make you initially very nervous and kind of restless and kind of shaky, and you can really feel that your heart rate is increasing. But once you inhale it slowly and let the medication work, you tend to settle down a little bit, and you don't feel that restlessness and agitation as much anymore. You should always use it cautiously in patients that have a history of cardiac problems. You might see some EKG changes such as prolonged QT intervals, and you would also use it cautiously if your patients were on beta blockers, because that would induce bronchospasms. Avoid foods with caffeine or drinking a lot of coffee or drinks that have a high content of caffeine due to the tremors and the nervousness and palpitations. Many times, if people do not use this medication correctly, or if they overdose on the medication, it can cause cardiac arrhythmias, hypokalemia, hyperglycemia, and possible cardiac arrest and death. Always important when administering these medications to assess your patient's medical history and any type of allergies, and to know their blood pressure, heart rate, and respiratory rate, and maybe to look a little bit in their history of their cardiac status, and maybe looking at their last EKG, and of course to assess lab work such as CBC and DIF, as well as an electrolyte panel. And of course to definitely assess their respiratory status, how severe their shortness of breath is or the dyspnea is. But that's what albuterol is about. All right, our next medication that I want to talk about is called ipratropium, all right, also known as Atrovent. This is also therapeutically used for as a bronchodilator, but pharmacologically it's an anticholinergic. And we've kind of talked about those, and I'm sure you've talked about some of those in Nursing 123. And what ipratropium is a drug that's a long-acting beta-2 adrenergic. It also relieves bronchospasms and asthma in even patients who have COPD. It also decreases nasal drainage in the common cold and produces a relief of excessive nasal secretions, and also rhinitis, where people have that year-round nasal congestion as well. It bronchodilates by blocking those cholinergic receptors in the bronchial smooth muscle, and intranasally it blocks that parasympathetic receptors, thus decreasing nasal secretions in the cold. Be very aware of anybody with glaucoma, because using this drug will worsen glaucoma, and it presents all those anticholinergic side effects such as dry mouth, nausea, GI distress, cough, dry nasal mucosa, hoarseness, and possible epistaxis because of the drying out of the nasal mucous membranes. You may see people develop paroxysmal bronchospasms. Avoid if sensitive to soybeans, peanuts, or soy lecithin. Avoid in urinary obstruction, and avoid use with atropine. Okay? Think about it. Because of the side or adverse effects of dry mouth, it's really beneficial to encourage patients to drink lots of water. They may see an increased heart rate. They may have a cough because of those anticholinergic effects, and to be sure that the patient is being provided good mouth care as well. Be careful, as I said before, of anybody with already increased intraocular pressure. You would not want to use this medication. That's why it's really important that the more we know about our patients and know about our patients' history and medical history and some of the issues and problems they may have, really helps us to determine if this is the best choice of medications for these patients as well. All right, so that's ipratropium, okay, which is a bronchodilator, anticholinergic drug, long-term, beta-2 adrenergic. This would not be a drug that you would use as a rescue like you would with your albuterol, okay? Usually these patients are on this on a daily basis, and it takes maybe a couple weeks to get the full effect of these drugs as well. The next med I'm going to talk about is Beckinase AQ. It's therapeutically an anti-inflammatory, and pharmacologically it's a corticosteroid. Remember how I began this lecture and talked about what occurs when a patient has an exacerbation of COPD or asthma? You have that inflammatory response that occurs with that occurrence of that attack. And so this makes sense that we would see this drug ordered for our patient. It can be given for someone who has asthma and for someone who has such a problem as allergic rhinitis. It's used as a nasal spray, and you would the patient would provide themselves 2 sprays in each nostril 2 times a day. It can also be used for congestion, sneezing, runny nose, and many times patients who have had nasal polyps removed to prevent them from returning. You might see this used in patients to prevent the return of nasal polyps after they've had some type of surgery. It helps to reduce inflammation and the immune responses, thus decreasing the frequency of asthma attacks. And a patient would be on this on a daily basis to prevent the possibility of an attack occurring. There is always the potential for corticosteroid toxicity, where a patient would develop dry mouth, hoarseness, changes in taste. Some people are more prone to cataracts, especially adults, and it can also mask signs of infection. You should not use it if you already have an infection or a fungal infection of the throat. It's used for long-term therapy, and it's not for acute episodes, okay? For acute an episode. It's important to be sure that the inhaler is properly cleaned, and to always assess the oral cavity to be sure that the patient hasn't developed any type of oral lesions or any type of infections that can occur, because it does mask signs of infection, and fungal infections are more at risk for occurring when a patient is on corticosteroid, especially when they're inhaling it. Okay, so that's Becanase AQ. Okay, the next medication I want to talk about is called Montelukast, and we might know that more as Singular. And therapeutically, it kind of is anti-inflammatory, but that's not really what the pharmacological classification is. It's a leukotriene modifier or leukotriene receptor antagonist. And what it does is, when it's, prescribed for somebody to take on a daily basis, whether or not you're having a asthma attack or you're having symptoms of allergic type of symptoms, what it does is it prevents airway edema and inflammation by blocking those leukotriene receptors in the airway. Because think about what happens when you, say for instance, have hay fever or have an allergy to something. That inflammatory response begins to occur, or histamine is released and mast cells, and that's when you get that congestion and edema, and your nose starts to run and all those kinds of things. It's used prophylactically with persistent chronic asthma, allergic rhinitis, and even exercise-induced bronchospasms. It's not to be used for an acute asthma attack, so if somebody, did not bring their inhaler, this would not be beneficial at all, okay? Headaches are one of the most common side effect. You can administer this to patients 12 months or older. There's a chewable form and a crushable form. It's contraindicated, obviously, just like I said, for acute asthmatic exacerbations or status asthmaticus. If given oral granules mixed with applesauce, carrots, rice, ice cream, or placed directly on the tongue. And there are some medication that may cause interactions, such as phenobarbital, Dilantin, may require increases in the dosing. All right. Again, as always, know what medications your patients are on, assess their medical history, assess allergies, know what their blood pressure, know these trends, and of course be aware of their latest lab work. And of course, because this is affecting their respiratory status, know the present condition of their respiratory status. Usually Singular is ordered 10 milligrams on a daily basis. So that's usually what we see prescribed for the patients. The next medication I want to talk about is theophylline. And theophylline comes in many forms. We can give this as an oral dose, or it can also be given IV. Therapeutically, it's known to help relax smooth muscles in the bronchioles, causing bronchodilation. And pharmacologically, it's what we call a methylxanthine. We may know this more familiar as a oral medication called Theodore. And how it works is it relaxes the bronchial smooth muscles. It helps to reduce inflammation. It relaxes those bronchospasms, which promotes bronchodilation. And it suppresses that airway responsiveness to stimuli that promote bronchospasm. So that treats that hyperresponsiveness that I was talking about when one has an exacerbation of either COPD or acute asthma attack. Now, a lot of patients who have respiratory issues are not necessarily on methylxanthine, okay, or a Theodore, or an IV form of a methylxanthine. What this is used for is when their first line medications that are prescribed to them are not really helping control the situation of their respiratory problems. And what I mean by that is, say for instance, it is a person that has asthma, and They've put them on some type of drug regimen, but they're not very well controlled. They're having frequent asthma attacks. They're having some respiratory distress. The medications they're on maybe are not really helping well, and maybe they've had some episodes where they've gone into a very serious exacerbation of their respiratory issues or illness. And so what happens is they may have to come to the ER to help combat those bronchospasms and their respiratory distress that they're experiencing. Because what happens is they may use their inhaler and the albuterol is just not responding. It's not providing the effect that we want it to, and these patients go into what we call a status asthmaticus or a further exacerbation of their COPD. So they obviously are in much respiratory distress, so they come in through the ER. This would be the drug they would probably use, okay? And we can give it to the patient IV route. Now, if they have been on this drug at home, say for instance they've been on an oral dose every day, the first thing that the physician would definitely want to order is a theophylline level, okay? To be sure that the patient has been on the correct prescribed dose. And we usually like to see that theophylline level usually within 10 to 20. Because if they have a very high theophylline level, it could be that these patients are experiencing toxicity from the medication, or if they're below that therapeutic range, it could be that the patient was not on a high enough dosage. Now, it has a good effect by actually relaxing those bronchospasms and kind of relaxing that smooth muscle, so the bronchioles will dilate and facilitate better movement of air. But there are some side effects that we could see that could tell us that the patient may have some type of toxicity, and that is where we see the patient have an extreme headache, irritability, insomnia, restlessness, a lot of nausea and vomiting, and diarrhea. It even could be as much as seizures and some dysrhythmias. Very important to cautiously use with patients who have a history of seizures or heart failure or any type of history of cardiac dysrhythmias. Use cautiously in patients that might have any type of liver disease, because this is obviously metabolized in the liver, and there are some drug interactions with many of the antibiotics and some of the anti-anxiety medications. When patients are on this, it's very important to teach them about limiting foods or drinks that have a lot of caffeine, because it could exacerbate the effects of the drug. So interactions would be cimetidine, which is Tagamet, which is an H2 receptor antagonist for people that might have GERDs or some type of GI distress, caffeine, phenobarbital, phenytoin, which is Dilantin or nicotine. Contraindicated for patients who can't stand cardiac stimulations, or as I said before, severe liver or renal impairment. Do not crush or chew sustained release. Chew chewable tablets thoroughly, okay? Or the enterocodone as well. So that's methylxanthine or theophylline, any type or any form of that type of drug. It is a bronchodilator, but pharmacologically it's what we call methylxanthine, okay? And like I said, not everybody is on this drug, usually used when we don't see the kind of effects we want to see from some of the routine drugs that we put our patients on who do have respiratory illnesses such as asthma or COPD. And the next drug I want to talk about is acetylcysteine. Might know it more familiar as Mucomyst. It's a mucolytic. Pharmacologically, it's an amino acid, and what this does is it helps to loosen thick, viscous bronchial secretions. This might be patients who have COPD, who have large amount of secretions due to the inflammatory response. For patients that have asthma, we might see this used for somebody who has cystic fibrosis. As we know, that disease causes a lot of accumulation of thick viscous secretions. Chronic bronchitis or other diseases that produce large amounts of secretions. We also see this used for Tylenol overdose, and it's if given IV. What it does is it actually breaks down the chemical structure of mucus molecules, making mucus thinner to clear by coughing. Okay. Obviously, a side effect, mucus can be a very dangerous substance where it can cause obstruction and severe respiratory distress. When someone continues to cough to try to expectorate these secretions, it can lead to a bronchospasm, GI distress, nausea and vomiting, contraindicated of giving PO or OD, and have gastric bleeding. So it's really important to assess secretions and to look at the consistency, and definitely many times with secretions we might send a specimen down for pathology to determine if there's any infection or organism growing in that. And it's very important to assess the secretions as to color, consistency, and amount, because many times when congestion and secretions are present, if it has a certain color, it might indicate and lead you to what kind of infection the patient may be experiencing, as well as the exacerbation of their respiratory problem. Again, assessing your patient's medical history, knowing of any allergies, assessing lab work, and most importantly, assessing the response the patient has to this medication. Is it helping to break down that mucus, and is the patient able to cough up their secretions as well? So really about watching their respiratory status. The next drug that I want to talk about is guaifenesin, which is also known as Mucinex. It's therapeutically used as an expectorant and pharmacologically as an expectorant. It treats dry, non-productive cough. It can sometimes work good with a productive cough, and again, this works by reducing the thickness or viscosity of bronchial secretions, thus increasing mucus flow that can be cleared by coughing. If you take too much of this, it can cause nausea, vomiting, abdominal pain, can cause dizziness or drowsiness, may develop allergic reactions such as a rash, can interact with heparin and increase the risk of hemorrhage. Contraindicated if the cough appears when the patient is on an ACE inhibitor for heart failure. When a person does have a lot of secretions, you might want to encourage the patient to increase their oral intake and to monitor other combinations of cold medications for guaifenesin. Should not be given to children under 6 years old as well. So I wanted to make that perfectly clear as well. All right. So those are some meds you might see for patients who have both either asthma or COPD. And you will be learning about these disease processes. All right, class, what we're going to do now is shift gears and talk about some of the medications that we would see prescribed for patients who have been diagnosed with congestive heart failure and coronary artery disease. Now, I do want to talk to you a little bit about these medications in general. You have already had these, or at least some of them or most of them, in Nursing 123. And the reason you learned about those medications because you were talking about patients who had the problem of hypertension. But now we see the same medications used for patients with these two problems, such as CAD and CHF. Now remember, the action of these drugs will not change, but I want you to think about why this particular medication is ordered for a patient who might have one or the other or both of these cardiac problems. You may not have had the lecture yet, but when we talk about coronary artery disease, we talk about patients who have atherosclerosis in their coronary arteries. And think back to Nursing 100 when we went over that anatomy and physiology and talked about the major coronary arteries and how they supply oxygen and blood to the heart muscle so that it functions properly. And then some of our patients have problems with the pumping or the filling of the heart muscle, and that's why they develop this disease called congestive heart failure. So let's take a look at these medications, and I'll review again the action of these drugs, but also to think about why your patient would be ordered or prescribed these drugs for these types of cardiac issues. Okay? All right, the first classification of drugs that I want to talk about are your calcium channel blockers. Now, up here on the screen, I do have the example of nifedipine, and that is an example of one of the calcium channel blockers, but we don't really give nifedipine a lot anymore, so I wanted to provide you with a prototype that is more often prescribed for our patients. And one that is prescribed frequently is diltiazem. Okay, you might know it as Cardizem, and it is for patients who have angina due to coronary artery disease. We might see it for patients with hypertension. That's where you initially learned about the drug, or your calcium channel blockers, or for patients that have arrhythmias. You may see diltiazem ordered for patients who go into a rhythm called atrial fibrillation. And like many other calcium channel blockers, diltiazem inhibits the transport of calcium into the myocardial cells, so that's why we call it a calcium channel blocker, okay? And it has the ability to relax both coronary and peripheral blood vessels. So think about it, when a patient does have CAD or angina, if we're relaxing those vessels, it opens up those vessels to allow better blood flow and perfusion to the heart muscle itself and to the other tissues and cells in the body, bringing more oxygen to the myocardium and definitely reducing that cardiac workload. When it's given PO, it might be given for patients who have stable or variant angina, and variant angina is angina that angina that's due to a patient developing spasms of the coronary arteries. And because this particular calcium channel blocker has the ability to relax that vessel, that prevents that spasm from occurring, causing a better flow of blood through that particular area. And again, this is why we give it for patients who have hypertension. It kind of decreases the contractility of the heart muscle as well, because remember, as we continue to get old, the vessels in our body are not as do not have that elasticity, and they tend to get stiff the older that we get. Diltiazem is also available by the IV route for the treatment of atrial dysrhythmias, particularly atrial fib. When it's given IV, it can really affect heart rate as well as blood pressure, so the patient is being continuously monitored as well, and cardioversion equipment must be available in case the patient still has a very high ventricular rate, and the patient doesn't respond well, except for maybe their blood pressure drops, but they're still not converting back into a regular sinus rhythm. The various extended release forms have different dosages, and they are not interchangeable, okay? Obviously, as a calcium channel blocker, some of the adverse effects or side effects of diltiazem are generally not serious and are related to vasodilatation, causing blood pressure to drop. Patient may have headache, dizziness, and edema of the ankles and feet, and abrupt withdrawal may precipitate an acute anginal episode. You would not give this medication in patients with an acute MI or any type of heart block or sick sinus syndrome as well, or even patients who come in with severe hypotension. Obviously, when we're giving some of these very potent and serious cardiac medications, we definitely want to evaluate our patient's kidney and liver function, looking at things such as GFR, BUN, creatinine, and of course some of the liver enzymes. Be always cautious with patients who are taking herbal supplements. St. John's wort or ginseng may decrease the effectiveness of diltiazem. Garlic, hawthorn, and golden seal may increase the antihypertensive effects of diltiazem. Okay. Treatment of overdose may be due to the fact that the patient has a very low heart rate. So atropine may be the drug of choice if that would occur when someone is using a calcium channel blocker. It may cause severe bradycardia, maybe by the fact that the patient is receiving too much of the drug. And if the patient really becomes extremely hypotensive, it might be necessary to infuse a vasopressor such as dopamine or dobutamine. Calcium chloride may be administered by slow IV push to reverse that hypotension or heart block that may be induced by calcium channel blockers. Because remember, think about it, how it works. It inhibits the transport of calcium into the myocardial cells, kind of tending the myocardium to kind of slow down when we're thinking about the conduction of the heart muscle. All right. So that's diltiazem. All right. So, and you can see that nifedipine has some of the same adverse effects as well, because it is in that group of classifications of calcium channel blockers, and many times we'll see those calcium channel blockers end with that suffix of -ine. The next drug I want to talk about is your ACE inhibitors, or what we call angiotensin converting enzyme inhibitors, where we see the suffix of PRIL, and our prototype for our ACEs is lisinopril. And lisinopril is therapeutically used as an antihypertensive, but pharmacologically it's an angiotensin converting enzyme inhibitor. Now this goes back to reviewing the renin-angiotensin-aldosterone system, because this is how your ACEs work, okay? It binds to and inhibits the action of an angiotensin converting enzyme, thus blocking the conversion of angiotensin 1 to angiotensin 2, and decrease in serum angiotensin 2 reduces aldosterone, which results in the loss of sodium and water retention. Usually the onset to peak onset happens within 1 hour after taking the medication, and it peaks in about 6 to 8 hours. Used with hypertension, CHF. Why do we use it with CHF? because think about our patients who have a poor pumping action. When we're talking about systolic heart failure, it reduces vascular volume to prevent that reabsorption of sodium and water back into the vascular space, causing the heart to have to work harder. So this is why we give our patients with heart failure ACE inhibitors. ACEs have a tendency to kind of vasodilate as well, and this is why when we administer ACEs, we definitely assess our patient's blood pressure and heart rate as well. It may take up to 2 to 3 weeks for these ACEs to provide the full effect of the drug. Some of the most common side effects are cough, and this is where you might hear that some patients develop that cough when they are started on ACEs. Headache, dizziness, definitely orthostatic hypotension, and sometimes rash. They're more susceptible to hyperkalemia, so it's necessary that we assess our patient's electrolytes. And then patients who have heart failure, and if you are taking care of a patient with heart failure who also has renal insufficiency, they're more at risk for hyperkalemia as well. Stop if a woman is possibly thinks she's pregnant. Use cautiously with NSAIDs due to worse renal disease. Use cautiously with patients who are on lithium, may cause toxicity, and do not take with Hawthorne due to possible addictive interaction. If a person overdoses on this, it may be necessary to provide hemodialysis for these patients. It's contraindicated with patients with angioedema, hypotension, or liver disease, and interactions would be potassium-sparing diuretics, antihypertensive drugs, NSAIDs, and food, as I just said before. And it's important to take on an empty stomach. So this is your ACEs, and our prototype for this group of drugs is lisinopril. I'm going to continue these medications on the next lecture video, because I only have the capacity to tape these lectures in hour intervals. So you will see this continued in part 2 of this week 2 lecture.